Good afternoon and welcome. I'm Mark McClellan, and on behalf of the Duke-Margolis Center for Health Policy, I'd like to welcome everyone today to our webinar on North Carolina's COVID-19 experience, examining opportunities to enable healthcare resilience during the pandemic and beyond. So today, we're focusing on healthcare and the pandemic. We want to talk about some current strategies for COVID-19 containment and care delivery, where healthcare has a critical role to play. And talk about what's working well, some additional opportunities to work better, and areas maybe where changes are needed to enable more effective pandemic response, and looking ahead to build a more resilient healthcare system. North Carolina has seen some persistent challenges in COVID-19, fortunately better than the experiences in some of the rest of the country, but like most of the United States, some real challenges in continuing spread of cases, testing positivity rates, and a persistent level of active cases and hospitalizations. We're seeing some changes here in the state and around the country towards behaviors like wearing masks and keeping distance and staying away from larger groups that seem to be helping, but clearly some room to go in terms of continuing hospitalizations, deaths, and significant disparities in the incidence and the outcomes of populations who have been affected by COVID-19. Healthcare organizations have a special role to play in the pandemic and in this country, and it's a challenging one. On the one hand, with the limitations of public health in the United States, we've asked healthcare organizations to step up and assist with public health responses and testing and containing outbreaks in communities. We're also asking healthcare organizations to deliver care in new ways so that people can get the care they need, especially those with serious illnesses or those who may have had challenges in getting access to treatments they need even before the pandemic began. And we're asking them to do this at a time when many of them are facing new and unprecedented financial challenges. Most of healthcare in this country has been paid for on a fee-for-service basis, meaning that when we went into more restrictions on movement and on activity, and when people stayed home, understandably, because of concerns about safety, we've seen a big drop-off in use of many medical services, again, at a time when healthcare response is perhaps needed in new ways more than ever. So given all of these challenges, we want to talk today about the opportunities to go forward. And it's especially important time in North Carolina. People may have forgotten, with everything happening with the pandemic, we're in the midst of a healthcare transformation in the state as well, with the state's Medicaid program planning to move into a managed care approach with new models for payment, and with many private insurers and many healthcare organizations in the state seeking to move away from fee-for-service because of some of the challenges that have come to the forefront in the pandemic as well. So today we're going to talk about the current challenges in the healthcare system and how we go forward during the pandemic, how to build a stronger system, one that can do more to address health disparities and provide seamless, high-quality care, maybe that builds on the silver lining of new ways of delivering care that we found perhaps work as well or better in the pandemic, with an emphasis on care that's at home and care that addresses risks and tries to manage them up front, detect and manage risks up front, rather than waiting for complications that lead to hospitalizations. We're going to start out with a fireside chat with North Carolina Department of Health and Human Services Secretary Mandy Cohen, a very busy person that you all have probably seen every day lately with her briefings on the latest developments and recommendations related to responding to COVID-19 here in the state. And she's going to talk to us some about how the pandemic has shaped the department's vision for healthcare going forward, and some of the steps that they're taking to address these challenges in our healthcare system. We're then going to have two separate sessions, one on enabling COVID-19 containment and care delivery, where our panelists will talk about how COVID-19 has affected their work and identify some areas where opportunities for further improvements in responding to the challenges that we're facing right now are possible. Then in the second session, we'll talk about a path forward, building a resilient healthcare system in North Carolina. We're not through this by any means, but it is time to look ahead. I don't think anyone wants to go back to healthcare the way it was before, especially after what we've learned during the pandemic of what might be possible to do better, where there are important gaps that need to be addressed, and also some innovative ways of meeting the challenges for delivering access to affordable, high-quality healthcare. Before we get started, just a couple of housekeeping notes. The webcast is being recorded and will be available on the Duke-Margolis website following this event. All the participants are going to be muted during the duration of the webcast. We do want to hear from you as we move forward with our discussions today. If you'd like to submit a question or comment, you can tweet it to hashtag NC Healthcare Resilience. That's hashtag NC Healthcare Resilience, or email it to us at margolisevents@duke.edu. That's Margolis Events, all one word, @duke.edu. We'll be capturing these submissions and we're going to work to address them during the course of the webinar. But right now, I'm very pleased to introduce Dr. Mandy Cohen, Secretary of the Department of Health and Human Services. Mandy, thanks so much for being with us today. We've appreciated the opportunities to work with you during your entire tenure focusing on health reform. I'm not sure this is what you signed up for when you moved into the job, but would like to hear from you about what some of the high priority policy changes are that HHS has implemented to enable the healthcare system, working with public health and really everybody in North Carolina communities to respond to the pandemic.
Well, hi, Mark, and great to be with you. And thanks for highlighting the work that is going on across the state of North Carolina. I'm really proud of the way our state has been able to respond to this pandemic. We took early action as a collective state to make sure we never got a first surge that was seen in the Northeast. And I'm proud to say that even as we see things surging in the South, particularly in the Southeast, I'm about to share the latest update on our trends to say that actually we've stabilized over the last 2 weeks, which is a feat given everyone else is really on fire around us. So I think the work has been tremendous, and it doesn't come from the state alone. It's been a tremendous partnership with so many entities. As I think back to some of the critical things we did right from the beginning to make sure that we were set up for success, and how did we enable the healthcare system to really respond, I think right off the bat, we went straight into surge planning mode with our hospitals, not knowing what would we need and how much capacity would we need. So there were waivers and trying to help folks think about both planning for increasing capacity within their walls, but also thinking, how do you want to think about hospital care at home and in other locations? We certainly went the route of a lot of other payers in the Medicaid program with telehealth flexibility, tons of flexibility. Our team worked tirelessly to put tons of changes in place, not just for physical health, but for behavioral health as well. I think we've done something like 500,000 telehealth claims at this point, which is about 4,000 claims a day for telehealth. But as you pointed out, it was also a really unstable time financially for folks. So the Medicaid program said, how could we accelerate payments? We did about $1.6 billion in accelerated payments for hospitals, another $50 million for other providers in the state. Again, they're Band-Aids. There weren't perfect solutions, but at least trying to help get folks to have some stability as we tried to build up our capacity. And then it was a lot of focus on our long-term care sites, which we're seeing a surging of some cases, and obviously some deaths in our most medically frail. And also, as you think about patient movement throughout our hospital systems and discharges, that was really important. So we did things like limit visitations, increase rates to our long-term care settings so that they could do the infection controls that they needed. We pushed PPE to them. We made sure testing was available if there was any cases. So that was a lot of the early work. And I think as we've matured the work through the months of April, May, and June, I think now we're getting into a much better place where we have better data infrastructure. And I bet we'll talk more about data that allows better visibility, much more nuanced decision making. Before we sort of had to take very crude action, where I think now we can take much more nuanced action as we think about living with this virus. And then I think aside from all the healthcare things, you know that the big thing for North Carolina was really thinking about health broadly, and that has not changed in the pandemic. And if anything has become more important, that health is not just health care, that health is really that full picture of what is making up your health. And the economic instability is really contributing to people's health as well. Obviously, we're not a Medicaid expansion state. That is a black eye for North Carolina. It's something I wish we could rectify soon, and I hope we will. But we also did continue our work to think about whole person. So whether that was getting out extra food and nutrition benefits to our families that have school-age children, we got about millions of dollars out to about 800,000 families for food, right? So food security, housing security. We finished implementation of NC Care 360, I think a really important platform to link together health and human services. So a lot of that work still continued on here in North Carolina. So we've been busy, and thank you.
Yeah.
Many partners are going to hear from have been tremendous. Like I said, this has been a huge team effort here.
Yeah, it is notable that compared to other states in the South, it's been tough, but North Carolina has done relatively better. And this plateau that you mentioned now is a much lower level than what we're seeing in other parts of the South. And you mentioned how this focus on health was there before, the early attention to closures and the like. But you also mentioned data. And one of the challenges with healthcare that really focuses on health, people before the pandemic talked about the silos that, there's hospital care over here paid one way, there's primary care, there's long-term care services, there's the stuff that besides healthcare that really matters, the social factors that influence outcomes. And it seems like we've had fragmentation of data there, but also fragmentation of data when it comes to healthcare and public health working together in the pandemic. Maybe you could talk a little bit about how you've tried to address some of those challenges and getting the data needed to respond effectively for population health now in pandemic times.
Yes, well, so data is so important to our decision making, and early on we had to make some pretty big decisions without a lot of data visibility. And I'd say we spent a number of months building up our data infrastructure to really be sharing information to understand what hospital capacity was, where our patient movement was, what is going on in our long-term care facilities, are they testing? And we're still working on that to continue to improve. We have definitely tried to take a data-driven strategy approach, and having metrics that were stratified by age and race, ethnicity, gender have been really important, because it's actually changed the way in which we do resource allocation. So when we saw our cases starting to go up in our Latinx Hispanic community, we turned our entire way of responding based on that data, and have very much shifted both our partnerships, the way we surge our testing capacity, and such. And I think that data is such an important component to maintaining and building public trust. And that is such a key component to fighting this pandemic, is because the science is evolving and things are changing day to day. So having the ability to have accurate and timely data that we can share day over day, and that I can go in front of the press, which I'm going to do again this afternoon, and say, look at these graphs, here's what we're looking at, is, I think, really important from a trust factor. And I think as healthcare thinks about what is next for it, and it thinks about how do we want to maintain trust within the healthcare system, I think transparency among data and that ability for apples to apples comparison and data sharing to build that trust is going to be so critical. I have found it to be one of the most important tools that we have in fighting this pandemic.
Yeah, that's very interesting to hear. And I do want to talk about where healthcare goes from here, to the extent there's a silver lining or things that we can learn from and make better. The pandemic certainly driven some big changes in care. You mentioned the shift to telehealth visits and the like, driven some new steps on data collection, getting out in the communities, understanding health disparities and helping you make decisions about it. Can you talk a little bit more about what you see going forward? What would you like to have happen building from where we are now in terms of the ability of our healthcare in the state of North Carolina to help manage and contain the pandemic, maybe address some of the disparities more effectively, and also to come out of this with, not going back to where we were before, but building on this experience.
Well, so I'll start with my theme that everyone knows that I'm on is like the buying health theme, right? If we're going to use our resources, I want to make sure we're going to get the most health that we can for our society out of it. And that means thinking differently and about linking things differently. So as I think about our response to the pandemic, right, it starts with the prevention of viral spread, and then it's testing and it's tracing, but then it's access to care and isolation supports. It's sort of the whole continuum. I think healthcare needs to also do that. So, and I think data underlies all of that because there's silos. The human services talks to each other, public health talks to each other, healthcare, physical health talks to each other, mental health. No, and we really need to get to that shared understanding of this. It's the same person that we're helping, and so how do we both become more efficient with that data understanding? But it's also linking of the incentives. And I know, Mark, this is where your life's work here, and like how do we get the incentives right to make that possible? So I think there's a data infrastructure piece that I hope this pandemic will help accelerate. But then there's the incentive piece that we need to layer on. And I think that we have some opportunity with some of the CARES dollars, and we're trying to be strategic about that can help us move the needle so that we can make some changes in the incentives as we move our Medicaid program to managed care, for example, to make sure we get the incentives right to keep promoting that whole person thinking as we think about health. So I think that's one. I think the other big thing for me is the moment that we're in with everything going on with the racial inequities and understanding the health disparities and this moment. I think healthcare needs to meet this moment and lead. I think we have looked for decades at our own data saying like, oh, there are health disparities. Well, it's time to stop just looking and to act. And what are the things that this crisis can help us learn in terms of how do we surge resources? What is the kind of linguistic and cultural appropriateness? And I think that whole person understanding will help us get at some of these equity issues as well. So I hope that's right. And then the last is about place, right? We're all working in different ways and using our time differently. Look, we're not in person here doing this fireside chat. We're doing it over Zoom. And so how does healthcare evolve to this new way of us thinking about place? How much work is going to happen in the walls of hospitals versus other places? And how do we really incorporate right place, right time, right provider for the kinds of things that we need? I think healthcare is such a high touch, importantly, very personal thing where you want personal interaction, but then there are pieces of it that aren't that personal. And so how do we differentiate from the things we want to keep high touch to the things that we probably can be moving online and can become more, and I don't mean just telehealth. And frankly, someone was saying that we don't call telebanking, we just call it banking. And when are we going to move to the place that it's just healthcare or it's just health? It's the way we access health, and it's not telehealth. It's just part of who we are, what we do. So I'm hoping a lot of that rethink will be part of what stays after this pandemic.
Yeah, actually, that co-envision has some recollections for me of the co-envision before we started. You talked about buying health. Before this, you were on track to moving healthcare payment along with the data sharing into more person focused, like through medical homes and accountable care organizations. That still sounds like it's the vision and maybe reinforced by and maybe redirected a bit by some of the experiences here.
I think we needed to accelerate some pieces of it, particularly the equity pieces. And I think having that equity lens definitely get accelerated. But yes, I guess I'm a one-trick pony. You're going to keep hearing whole person health from me and buying health. I just think it's so core and fundamental. And I think this crisis has just shown us that we have a lot of gaps when we go into a crisis. And how do we think about using some of the tools that the healthcare system has, and particularly the resources that we can, and how do we deploy them to be best at responding?
And we really want to thank you for taking the time with us. One last question. People are very interested in schools reopening and businesses continuing. Seems like the key factor, the most important thing in all of that is getting the case rate down so people can get out more safely. What's the biggest next step that you'd like to see our healthcare in the state, our health professionals focus on to help make that happen, to get the case rate down?
Yeah, it's really important, and there's no one industry that's going to help. But I think healthcare, as leaders, we understand the science differently. But look, we also know hospital systems. You guys are big businesses. I need to think about using your voice both as leaders in your community, but advertising dollars and marketing. Blue Cross, I really appreciate, has brought together a bunch of the business leaders to say, how do we all use our voice collectively in the same vein? Let's all market the 3 W's that we've been talking about in North Carolina, the wearing a face covering, waiting 6 feet apart, washing hands. Let's all kind of put our own spin on it, but all do that same messaging together. I think that is really powerful. So I think there's a lot healthcare is going to do to respond to sick people walking through their doors. But this is a moment where we also have to be working on the prevention side of it, or the lowering the spread of the virus. And so please do your 3 W's. Please be a leader. I mean, there's been nearly all of the hospital CEOs have been fantastic on this, getting out in the community. They're on TV. Gene Woods was just on the Sunday shows, again, really representing North Carolina, but also representing healthcare and the kind of voice that we can have in this. So I'm really proud of where North Carolina is.
Secretary Cohen, thanks for your time, your leadership, and energy, since you've got another briefing coming up after this. We really appreciate your joining us today.
Thanks, Mark.
And now I'd like to move to our first panel on enabling COVID containment and care delivery, which will be moderated by Dr. Charlene Wang, who is Executive Director of North Carolina Integrated Care for Kids and an Assistant Professor of Pediatrics and Public Policy at Duke, and a member of our core faculty at the Duke-Margolis Center for Health Policy. Charlene?
Thanks so much, Mark. I'm really excited to moderate this important conversation. In this particular panel, we're going to be focusing on examples of COVID-19 containment strategies, as well as other care improvement strategies. And I'm trying to really identify some of these policies and practices and infrastructure changes necessary to continuing to do better in North Carolina, as the Secretary was just highlighting. Here with us today, we've got Dr. Matt Ewan, the Chief Clinical Officer from UNC Healthcare and President of UNC Physicians, Dr. Brian Cavaney, the Executive Vice President and President of Diagnostics at Labcorps, and Anita Bachman, the CEO of United Healthcare Community Plan. So thanks to all of you all for joining us. So now we're going to have each of you just go down the row. We'll start with Dr. Ewan to take a few minutes just to introduce yourself just a little bit more and chat just for a few minutes about how your organization has been engaged in COVID containment and care delivery improvements. So Matt, let's start with you.
Great, Charlene, thank you very much. And good afternoon, everyone. I'm Matt Ewan. Since March, I've been helping to lead UNC Health's response to the COVID pandemic. We characterize it as chaotic and challenging, but at times also very rewarding. We pulled together a team of clinical leaders, researchers, hospital leaders, administrators, and started to build for what Dr. Cohen described well as a surge. It's turned out to be more of a marathon, but I think some of the strategies that were put in place early have transitioned well. I'll just, in the interest of time, just very quickly mention 4. The first was the strategy of building out the respiratory diagnostic centers. These are sort of the drive-up clinics where we send folks who are worried or have signs and symptoms of COVID infection. And that's really allowed us to get those people out of our normal healthcare environment, which protects our coworkers and protects our other patients. And we run 11 of those around the state. So that's been a big investment and something that we'll keep with as long as it's needed. The second strategy was to protect our workforce. Very early on, we identified both the health and the well-being of our workforce, and we separated those. The health really was keeping them from getting infected with this, and the well-being was to help them to stay out of some of the dark places that providers have gone as they've tried to get through this pandemic. And so on the health side, we tried to be very creative with PPE, and we used engineering and administrative controls as well as just PPE. So we kept people out of situations where they might get exposed. And then on the well-being side, we have a really wide system-wide all-worker well-being program. Just highlight the Healthcare Hero app that Sam McLean from our emergency and anesthesia group built, that was featured on the morning shows a couple of weeks ago. I think our third principle was to over-prepare. So we have models. We've partnered with the state, with the Margolis Center, with others to build those models, and we've always built to the high end of those models, the 90th percentile. We've asked our folks to do the same. We stopped surgery for a while until we better understood the disease and our care pathways and what our supply chain was. And then the fourth, which I think is something that's just going to be brought up time and time again during the course of our time together today, is telehealth, and really to meet patients where they are, to keep them out of emergency rooms, out of clinics. And that's really been transformative in the way that we deliver care. And that's been a partnership with IT, with patients, with payers, with the state, and one that we're very proud to be part of. So we're committed to helping the state through this pandemic, and I look forward to a really good discussion. Thank you.
Thanks, Matt. Brian, do you want to go next?
Happy to. Thanks, Dr. Wang. Good to be with you and everybody on the call today. So Brian Cavaney from Labcorps. We're a global life sciences company, but since we're focused on North Carolina today, I would say that we're the home team with about 9,000 employees here in North Carolina. In fact, I'm sitting in my office in Burlington, North Carolina, looking out at the one building that has probably done more COVID-19 testing than any other single facility on planet Earth since this started. You know, we were lucky enough to work very closely in a public-private partnership for many, many years, for many different pandemics with all the health departments, but in particular the CDC. And no exception in this regard. It just highlights the importance of preparedness, thinking ahead, and making sure that the scientific community is always in touch with each other. We actually have a very large lab as part of our clinical research business, not terribly far from Wuhan, China. So we've literally been very aware of this and thinking about it with our own employee population since December of 2019, when this became known around the world. We were fortunate enough, because we worked so closely with the CDC, the FDA, the NIH, and others, to launch the first assay back on March 5th. And if you'll remember the capacity crunch that we had back then, most of the state health departments were able to do somewhere between 50 and 100 tests per day. And we were amazed that that first week of March, we were able to do about 2,000 tests per week. And now, even though the demand has gone dramatically up, and there continues to be significant media interest in making sure we have adequate testing, and we certainly don't have enough globally or locally yet, we are able to do about 180,000 tests per day. But yet that still doesn't meet the actual demand needed across the system. So there are just so many different issues that we could dive into, both to make sure that we adequately address our current needs and the potential co-infection that's going to happen this fall with flu season and all that might portend, and then really getting ready for the next pandemic. You know, we're lucky enough that part of our, about a third of our company is global clinical research, and we're very fortunate that we are probably more involved in more vaccine and therapy trials than anyone else on Earth. And enrolling patients into trials because we're doing a large amount of the testing. We're identifying positive patients early. We're doing antibody testing. So we're able to quickly figure out who should be enrolled in different clinical trials and trying to learn as much as we can and contribute to the scientific community. And we all know that, you know, we're going to do the best we can. The public health measures are the most important thing. Testing is a tiny but important part of that, basically just a scoreboard to know where the cases are, to then enact all of the important public health measures. But ultimately, it's the development of new therapies and treatments, and then eventually vaccines, which provide the most hope for really containing this, and then getting back to some sense of normalcy so that we can all mostly go back to our day jobs and take care of the patients that still have every single condition and disease that they had the day before they knew about COVID, before it upended their world and changed all of their health behaviors. So we look forward to that day.
Thanks so much, Brian. And I will say, as a practicing primary care pediatrician, we are thinking a lot about that viral respiratory season that's coming, when clinics are typically full anyways of runny noses and fevers and such. Anita, wanted to turn to you.
Good afternoon, and thank you, Dr. Wang. What a pleasure it is to join this panel today. Just quickly, I'm the CEO of United Healthcare North Carolina that serves our Medicaid and our dual eligibles population. Maybe share just a few things about our enterprise, and then also United Healthcare. So United Healthcare is a part of United Health Group, which is an international enterprise. that does provide a broad spectrum of products and services through really two distinct platforms. First is United Healthcare, which most people are very familiar with. It is a company that serves all populations, our employer-sponsored, Medicare, Medicaid, dual eligibles, and individuals. And we serve currently over 50 million individuals across the country, providing and managing their health benefits. And then the other part of our enterprise is Optum, which many of you as well may know. That is our company that is focused on providing information and technology-enabled health services to really focus on simplifying the healthcare system. We also provide healthcare delivery of services as well through surgical centers and primary care providers. And we, through that division, serve approximately 127 million individuals. Bringing it closer to home, United Healthcare North Carolina. So we were actually started in North Carolina, in the Triad area of North Carolina, well over 30 years ago. Currently have over 6,000 employees that are based and working out of North Carolina, and have the privilege of serving over 1.4 million individuals in the state. And that includes, again, both employer-sponsored Medicare, dual eligibles, and individuals. And we look forward to serving the Medicaid population through the new Medicaid Managed Care program in 2021. Obviously, our focus has been through this pandemic is supporting both our members, those that we serve here in North Carolina, across the country, our provider partners, the hundreds of community-based organizations that we work so closely with, and as well as just the communities in general. A lot of our focus has been on ensuring that people have the coverage, they have the benefits, that there are no barriers to them getting access to health care, and then obviously working with our providers to ensure that access can be increased in all ways. So I look forward to sharing more of the specifics of some of the initiatives and programs that we've launched in the discussion this afternoon.
Great, thanks so much. So one question just to kick us off, to really build off of some of Secretary Cohen's comments about the issues of disparities and how healthcare really needs to meet this moment and lead, and not just talk about how we know we've got a lot of disparities. From what you all are seeing, and we've certainly seen these disparities really in a much starker contrast in many ways because of the COVID-19 pandemic, are there any policies that either you all have enacted locally within your organizations, or that you've seen the state or federal entities enact, that have either helped or exacerbated the disparities that were already existing during the public health emergency, including things like access to testing, telehealth, and other virtual care services? Whoever wants to jump in first, feel free.
Yeah. Hey, Dr. Wang, this is Anita. Maybe I'll just start off quickly. So we have been so excited to see a number of regulatory policies and flexibilities that states have passed throughout the country to really address, I think, one of the most important things in this pandemic, and that is access to healthcare services. And as Secretary Cohen mentioned a few minutes ago, you know, the digital platform and telehealth services, while we know that's been important, I think there's been an increasing need for telehealth services because so many individuals have been at home, right, and have not been able to go to receive services within their hospital or within their primary care practice. So I think increasing access, I think the flexibility that states have shown to really not only cover those telehealth services, but expand some of the coverage of telehealth services. And as a result of some of the policy changes, we've actually seen at United Healthcare telehealth services quadruple in utilization over the last 90 to 100 days, and hope and anticipate that that will only continue. I think people are beginning to feel more comfortable with the use of telehealth services, understand now that it's a confidential and a very safe way of getting healthcare services provided. Here at United Healthcare, to ensure that there was no barrier to receiving their services, we waived all cost sharing related to telehealth services. There was no limit on telehealth services so that people could get those. And then in addition to that, we waived all cost sharing associated with any COVID testing, any diagnostic treatments, and then overall treatment, again, making sure people felt very comfortable in getting those services. As well, I think from a regulatory perspective, we saw some regulatory flexibilities with increasing payments to providers. So with skilled nursing facilities, primary care practices, also with personal care services. And in some states, we've actually seen some payment adjustments for non-emergency medical transportation. Again, opening up access so that people could get the care that they needed when needed. And last, I would also point the flexibility around how and where health services could be provided. So we saw New York as an example, the setting up of tents, not only for COVID testing, but for actual treatment of COVID services. We've also seen the use of hotels and motels really open up for people to be able to go there and get healthcare services. I'll share with you just quickly a partnership that we had in Camden, New Jersey. There was a hotel that was not being utilized fully. And so we worked with the state and with the Camden community and really helped support the opening up, or really the transformation of that hotel into a place where individuals that were diagnosed with COVID could come in there, receive very targeted care while they were there, and then also help to prepare them for a safe and smooth transition back into the home. So again, I think there's some of the flexibilities that we've seen across many, many states, including North Carolina, that I think truly have opened up and increased access at a very, very important, critical time.
Let me just ask a quick follow-up, and as you guys are answering too, if any of you all have any preliminary data, for example, about thinking about who's getting access to some of these fantastic new services that are enabled virtually. I think there's been some data coming out from other states that perhaps that access, even though it's fantastic, is not being used equally by different populations who might need it. So I don't know if Dr. Ewan or Dr. Cavaney or Ms. Bachman have any other comments about that with disparities.
Yes, Charlene, I think it is really a problem that we've gone very quickly into virtual health, and I think most big organizations like ours feel pretty good about that rate of acceleration. But there are a lot of very important parts of our healthcare system that aren't part of these big systems, and getting all of those groups up to speed with virtual care is, I think, going to be a shared responsibility among all of us. So we have a clinically integrated network with about 6,000 providers, and about 2/3 of those folks work directly for UNC, but the rest are independent groups, and we work really hard to bring resources to those primarily independent providers, knowing that that expands the reach. The other thing I think we'd probably touch on under this is just the importance of getting testing into the communities where people live. And so we've taken 2 of our buses that we used for mammography and for vascular screening and repurposed those as mobile COVID testing centers and brought them into communities in partnerships with existing community organizations, faith-based organizations, so that we could get not just testing, but also address some basic social needs, hand out masks, access for behavioral health services. So those are a couple of things that we're trying to do.
Charlene, I might add just a couple of other things from our perspective. So I think the fact that there was a national declaration of a public health emergency early on was actually critically important to trigger a whole host of other administrative law functions and federal and state activities. And it enabled us to have literally daily conversations with the CDC and the FDA using the emergency use authorization pathways to literally create and share the data together in real time with the regulatory bodies so that we could get our various diagnostic testing on the market as quickly as possible while generating all of the data necessary to demonstrate its capacity. In terms of the actual communities where we knew very early on, and even from some of the other countries before there was massive spread here, that it was impacting certain subsets of patients, populations, ethnicities, certain gender differences, et cetera. The fact that for many years, we've already had a very robust data and reporting system under the Communicable Disease Reporting Standard. So we already, pre-COVID, were sending a couple of million lab tests per day to health departments and to the CDC every day. Those pipes were built, and we simply added some extra data fields after conversations with some of the scientists and public health authorities to make sure that we could get as much of that data as possible. The fact that we had good collaborative conversations with the health departments, with congressional delegations, with the federal government, and certainly with all of the private payers with whom we work all the time, we had great foresight that there was bipartisan certainty that there was going to be collaboration to address the issue. And we did something like 800,000 or 900,000 tests before there was even a CPT code, before there was any payment process, before Medicare had come up with any of its fee schedules, et cetera. We just knew and relied on the fact that there was going to be this groundswell of support for addressing that issue. That also enabled us to have basically a standing policy that we wouldn't have any upfront costs for anyone through any of our mechanisms, whether they were insured or not. And then the CARES Act and the Families First Act kind of reinforced that and created a mechanism for the uninsurance payment fund for testing, and working even with the private sector managed care plans, such that we're the back-end testing lab for many of the retail pharmacies and the others that particularly had served the federal and state drive-thrus that you've seen on the media. And that enabled us actually to use our data and very specifically work with CVS, Walgreens, and the others to identify the underserved communities that also had the particular ethnic and demographic makeup that fit the prediction of higher severity, and actually do more testing specifically in those neighborhoods or parts of the country. Again, knowing that we didn't have to worry about insurance coverage or funding or these other things. The mandate was just go to where the testing is most needed. And it was amazing to see the public-private partnership to rally around that and make sure that it actually was trying to address health disparities at its core.
Fantastic to hear. So Brian, we actually have another question for you, and also one from one of the audience members. So just wondering if you could talk a little bit more about the challenges of testing demand versus supply, which you've touched on a little bit about already. And one of the questions from the audience includes what to do about the delayed reporting that we're hearing with COVID-19. Again, this is something that has gotten better over time, but certainly we're still hearing there are a lot of delayed reports of results, positive and negative. And is there anything that Labcorps is trying to do to move to a faster timeline on those? Because obviously the disruption for families who are waiting, patients and families who are waiting for those results are massive.
Great and complicated set of questions, absolutely. First of all, it's an incredibly global supply chain to create that. Normally in healthcare, it's a very stable, predictable market. I mean, actuaries are incredibly good at prognosticating exactly how much healthcare is going to be consumed a year or two in advance when they're doing things like that. All bets were off with this. So for example, we've gone through multiple phases that completely changed the demand and capacity curves. In the very beginning, February and March, when there was literally almost no testing available, doctors couldn't get it for their patients. There was an overwhelming run on the bank mentality, and it just wasn't available. So the public health authorities had to come up with very strict guidelines for who was prioritized for getting testing. Once all of the states essentially went into shelter-in-place lockdowns and 30 to 35% of medical practices basically closed, people weren't going out, flu season was over, there was a massive drop-off in demand. And in fact, for a couple of months there, maybe April, May, we were using less than half of our actual capacity because doctors weren't ordering the testing and it wasn't necessary. Since then, we've probably quadrupled or quintupled our actual capacity. We're now doing testing in 20 labs across the country, and orders of magnitude more than we were doing in the beginning in March. And now, it kind of post 4th of July weekend, when most of the country has opened back up again, all sorts of summer activities have taken place. The protests all around the country, et cetera, there's been a massive swell of capacity. And in particular now with colleges, employers, others wanting to get into the game. And another important factor was the restart of many of the elective procedures and other medical surgeries, et cetera, which had been postponed, creating some pent up demand. So all of that demand coming together at once. We can do so much more testing now than we could in March and April, but yet the demand has now exceeded that. It is actually, with all due respect to the media, it's dramatically more complicated and sophisticated than is often portrayed. So for example, just the machines that we have, one of the basic ones is this Roche 8800 machine. It has more parts than a BMW, costs a heck of a lot more than a BMW, and takes up about the same amount of size. And you can get about 5,000 tests per day from that. So we have machines like that deployed all across the place. We get consumables, reagents, primer sequences, physical equipment, extractors from dozens of countries all around the world. So we're actually constantly talking with customs and Homeland Security and our trade representatives to make sure that we can move these goods all across the planet to install them in our labs and increase capacity to meet this growing demand. There's a host of other technologies that are being worked on, but the gold standard continues to be in-lab PCR technology for now, while lots of other things are eventually going to come to the market. And then hopefully we get a vaccine or some amazing treatment, and then the need for such high levels of testing goes away. And then it's probably more something like checking people's titers after they've had a vaccine to make sure they probably have conferred some level of immunity that does enable them to go back towards more activities of daily living and normal life activities.
So it sounds like a lot of work at this point, still waiting for some of these other products and tests to come to the market so we can get faster turnaround.
Yeah, you did ask about the turnaround time. So that also tends to be on a lag in the media. So we've taken a lot of different measures. We've asked the health officials around the country to continue to reinforce the importance of prioritization of guidelines. There was a very significant increase in turnaround time over the last couple of weeks, again, from 4th of July till about last week. We caught up dramatically over the weekend, and now for our prioritization process for hospitalized inpatients, it's down to about 1 to 2 days. And then for all the rest of the specimens we get, our average turnaround time is now 2 to 3 days. So it was almost a week last week on average, and now it's back down to 2 to 3 days. So we're dramatically more useful for doctors trying to make important clinical decisions, for hospitals trying to meter the very expensive and hard to get PPE that its healthcare workers are needing to use, the public health agencies trying to do appropriate tracking and tracing and telling people to isolate or quarantine until the results are back. So believe me, we know the importance and the pressure on getting that out. We've hired hundreds and hundreds of lab techs since March, and every one of our labs has been working 24/7. We just simply have these incredible supply constraints where we can only do as many results as we have every single piece of equipment, supply, and consumable that it takes to report every individual result. And we're on the phone with every vendor and manufacturer around the world every day to say, we'll buy more, whatever you make, we'll buy, and we will be able to use it and deploy it. And it's just incredible.
We're all very appreciative, of course, of your ability to help us build the testing capacity. And Anita and Matt, wanted to turn to you all for a last question for this panel, which is to think about, as we talked about with the Secretary, this acceleration also towards value. Obviously, Anita, you touched on this already. Matt and Anita, just curious about if you could share some of your thoughts on how COVID-19 has potentially accelerated or changed the way that your organization has thought about the move towards value.
Yeah.
You know, Dr.
Go ahead, please.
Go ahead.
I'll follow you.
Yeah, well, it's a great question, and United Healthcare has been committed to really developing value-based models and value purchasing, because it really does align incentives, and I think really does drive better outcomes for all. You know, currently, as we look across our entire United Healthcare business, about 60% of our dollars are spent in value-based arrangements today. And we are committed to improving that, increasing that every time. I think with this pandemic, it certainly has highlighted, again, the importance of aligning incentives, but really developing models that, to Secretary Cohen's point, is really around the value, drive better health, right? Many times these value-based arrangements have been focused on medical services, behavioral health services, and I think with this pandemic, I think it's further intensified the real need for us to focus with a wide-angle lens on health, and really looking at value-based arrangements that include those social determinants of health, those health disparities. And so I'm excited about the data that we have, the data we'll continue to use to really develop new models. I'm also excited about NC Care 360. So that is that new platform that is currently being rolled out in North Carolina, the first social determinant platform in the country, and being led in North Carolina, and the amount of data that's going to be available and really shared across providers, insurers, community-based organizations to ensure that individuals get the care that they need. So again, really excited about what the potential is with more new models and more dollars being invested in value-based models as we move forward.
Great, thanks.
Charlene, I just add a couple things to that. As you know, we've been enthusiastically running towards value-based care before there was a pandemic. I think the first thing it did was just highlight what an inadequate system fee-for-service is. And so suddenly all of these bills and codes and things that we have don't match up with the cost of care anymore. And a mask doesn't cost 25 cents, it costs $5, and you don't need one, you need 10. And we're still trying to pay for it with a system that measures each thing. And we could truly account for the cost of care, of caring for patients with COVID and the other diseases going on, we'll be able to get our hands around it. So the first thing I think it did was point out the importance of doing that. The teams that we had in place that were adept at managing folks out in the community and treating their overall health and doing prevention strategies were immediately helpful to us in reaching out to people who had COVID infections, particularly ones who weren't very sick and were at home. So those tools were really helpful and reinforced for us how powerful that was. And then I think this just all showed how interdependent we are. And our partnership with the payers and with independent doctors and with patients themselves. And I think the patients have, in my experience, never been more engaged in their own healthcare than they are right now. And that's really helpful when you try to get to a population-based healthcare strategy. So we'll get through this. It will be hard. We will get through it. And there will be a lot of good that comes from it. I just hate to see the amount of misery that it's creating for the people of our state.
Let me ask one more question also that came in from an audience member. Talking about value-based care, and Brian, you were just telling us so much about testing. What do you all think about the concept of payers linking payment for testing to timeliness of reporting results? Is that something that you all feel like your organizations would support, that you feel like would advance the containment strategies in North Carolina?
Well, I'm sure that's aimed at Brian, but I'm going to try to deflect him a little bit. This has forced us to improvise and to run as fast as we can towards something that changes when we get there. And so, I mean, I heard Brian say we can do 5 times as many tests as we can do, but you all are ordering 10 times as many tests. And certainly we want to reward good performance, but in something that's changing as quickly and as uncertain as this is, I think we should set realistic expectations about what we can do together. And if lots of people stayed home and wore masks, and the people ordering were careful to order tests in the right situation and to prioritize them so that Brian and his team would know these have to go today because everybody's wearing an N95 around this patient, and this is just a guy who plays pickup basketball at the Y and wants to know when he can go back, we could make a lot of progress working together on that. So Brian, I'll try to set you up.
That was fantastic, and I agree completely. I guess what I was going to say was what we need to do is make sure that it's focused on scientific evidence and clinical prioritization of who needs to be tested, as Matt said. You know, we're in network with 1,600 health plans plus every government program that exists. And I think what the public wouldn't like is if there was a perverse financial incentive for us to prioritize specimens from one payer that had some sort of a financial incentive for turnaround time, regardless of clinical need. So I would have to think a lot more about that. But on its face, I don't think that makes any sense from a public policy standpoint. I think we need to be incented to do everything we can to build the capacity that the country needs and to prioritize the specimens that need to be prioritized. Our guiding principle has actually been to do first in, first out, and not even consider the source of it, except for the clinical prioritization of the doctors ordering it, and focus on doing that on the upfront, and then getting every specimen through as quickly as we can in the order that they're delivered to us from the doctors.
Well, thanks so much. Thanks everyone for your time today, and thanks for all the work. It sounds like across our state, across our country, and Brian, you've highlighted across the globe really. So I'll turn it back over to Mark.
Hey, Charlene, thanks very much to you and all the panelists. That was a great discussion. You know, we could have a whole event on diagnostic testing for COVID, and we will. So stay tuned with Duke Margolis, more on that very important issue to come. But right now, I'd like to move us to our next panel on a path forward, building a resilient healthcare system in North Carolina. And this, we want to move from talking about where we are now, how we're facing some of the challenges today, to where are we going? We are by no means done with this pandemic. We are right in the midst of it, still have some challenging issues to get through, building on some of the promising steps that you've heard about already. And we're going to talk some more about that in this panel, where we go with the pandemic from here, but also about what's next. What kind of healthcare system are we moving into? As Secretary Cohen talked about at the top, keeping that focus on health. And very pleased to be joined for this panel with four terrific and diverse perspectives on where we are and where we are going. Dr. Karen Smith is physician and owner of her family medicine practice in Rayford, North Carolina. Dr. Shannon Dowler is Chief Medical Officer of North Carolina Medicaid in the Department of Health and Human Services, where she works on many of these payment and healthcare system issues. Steve Knorr is Senior Vice President of Population Health at Cone Health and Chief Administrative Officer of Triad Healthcare Network. And Dr. Rahul Rajkumar is Senior Vice President and Chief Medical Officer at Blue Cross of North Carolina. And I'm going to ask all of you to start off with some comments on this topic of what do you see as most important in getting from where we are to where we should be coming forward and out of the pandemic, talking about some of the things that you're doing now and planning to do. And I'd like to build on what we've heard in the last session as we look forward. Some key themes that came out from what we've heard so far. Data sharing, getting a focus on people, not just silos and services, whether it's healthcare needs or pandemic or COVID-19 risk or social needs. Second, reforming the way that healthcare is working with an emphasis on telehealth and really the digital health and virtual services that surround a telehealth visit with a more effective and convenient model of care for diverse populations. Also shifts in site of service, more out to the community at home and more convenient. We've talked about the importance of better diagnostic testing and more rapid diagnostic tests for COVID, but that would apply to risk factors for a lot of population health risks, including sharing some of that information with public health authorities. And we've seen healthcare costs go down, something that's been a big objective for people in health policy for a long time. And I think the question is whether as we go forward, some of the services that have gone away, maybe that weren't all that needed, those low value MRIs or lab tests or other procedures, are those going to stay away too as we go back in what will be, no doubt, tough economic times ahead. And then finally, cooperation, recognizing the interdependence of different parts of different organizations and coming together to improve health and address health disparities, whether it's related to healthcare services or social services, pulling all of that together and finding ways to share data and work together, even as we're involving a lot of organizations that do compete as well. So I'd like to go through our panelists with some opening comments on these topics. And Karen, maybe we could start with you.
Very good. I appreciate being here as hopefully I can provide the voice of the physician in the field, what we're doing in reality and what's working, what's not working. And so in our medical practice and probably several other practices throughout the state, we have the three areas of concern. And we started off with the simple physician well-being, and in some instances just being. The fear of COVID-19, if we were to maintain our practices and keep the doors open, would we get the virus? And several did close the practices, but then there were some of us who didn't have that ability or to do that. And what would happen to the patients in our community? We also had the issue of our staff and our team, encouraging them that if we practice those universal precautions that we had built up, that and follow the guidance of the leadership from our state. And if we could do that, then we certainly could move forward with the operations. The other area of concern was that of patient engagement. We had patients who didn't want to come into the office. They didn't want anything to do with healthcare facilities. And so now we had that matter. And then the third area was that of the medical practice, the business viability. Well, a long time ago, we had built our practice using the patient-centered medical home concept. And so I kind of like to think of it as the house flippers. So we were practicing medicine, and that healthcare was not allowing us to have accessible care. It wasn't good quality, it's like what we would like. We didn't have the best efficiency and was costing us a whole lot of money. And so we had to flip the healthcare house. We had to flip our business. And when we did that, we introduced the technology. And it's that technology, the workflow, the team engagement, that's what we are using to maintain and be resilient. Let me say this about resilience. I don't want to bounce back. I don't want to go back to where we were before COVID. I simply don't want to be there, because this is a magical moment in time, and it's a desperate time, allowing us to fast forward. So that's where I hope we can go. And that's what our team, and I suspect many practices across the state, have also looked at those 3 major areas and taken the opportunity of this magical yet desperate moment to fast forward.
Thanks very much, Karen. I'd like to turn to Shannon next.
Thanks. And thanks, Karen. Karen has been one of our experts on some of our Medicaid education sessions, and she has been a real early adopter, and she's set a great example on how to do telehealth really, really well. So from the Medicaid perspective, I will acknowledge that when I first got to Medicaid in the fall of last year, I recognized our telehealth was pretty far behind where we wanted it to be. As a matter of fact, Ben Money and I had already started a telehealth team in December with the goal of modernizing our telehealth. We were sort of lagging behind most other states from a Medicaid standpoint. Fast forward to COVID, where all of a sudden we got to do it really fast. We made over 300 provisions with over 500 codes that were modified in our system to allow for telehealth or virtual health. So rapid modifications to an archaic billing system, which was a huge accomplishment. And I think one of the things we did from the get-go was we looked at this with a quality lens and a data lens to study the telehealth provisions, and not just do telehealth, but let's study it and understand who's using it well, who's not. How can we use our existing resources like our practice management supports we have through AHEC and CCNC and point them to practices where they're not adopting telehealth. So don't just turn it on, see who's using it and help those who aren't using it get access to it. Communication has been a huge part of this. You know, we put out over 100 different bulletins in 2 months, which is, agony for practices to keep up with. We did weekly webinars where we'd have updates on what was happening with our policies. Essentially, it took us 2 months to move the engine to rapidly adopt all these clinical policy changes, which is amazing because normally one policy change can take 9 months. So we did, dozens and dozens and dozens of them in 2 months, which is awesome. But it was a lot for the field to adopt all at once. And then they had all the payers doing different things, which made it really challenging. And I think what really made resiliency take a hit on the provider side because it was very confusing and difficult to keep up with. But we did keep up weekly meetings. We had on average about 800 providers at each update. And I think that was really one of the things we did that was successful. I think one of the other things that we're really focused on right now is this health equity issue. And so over the month of May, we actually, while all this work was happening on telehealth, we also looked at all of our policies and asked the question of how does this policy inadvertently contribute to a health disparity? And so we started with looking at all of our prior authorizations and asked, does this prior authorization inadvertently create a health disparity? And so we've got a whole list of changes we're going to make to remove prior authorizations and other policy changes because we realized that maybe they were not helping the state in the way we wanted to. Secretary Cohen mentioned how we use the Medicaid dollar lever to get federal dollars to help support providers. We've been very focused on safety nets and trying to make sure our safety net providers were able to keep their heads above water during this by rate increases, medical home fee increases for everybody, rate increases on some of the virtual healthcare and how we paid for that. As we move forward, we're thinking a lot about managed care. I think we're already taking the lessons we learned from Managed Care 1.0, which we were supposed to have gone live with a few months ago. And we're saying, all right, how do we make 2.0 different and stronger and better? And in fact, even though North Carolina is one of the last states to get to managed care and Medicaid, we're asking ourselves, when we do go live, how are we going to be the best state? How are we going to be the gold standard by really looking at the future of healthcare provision and payment and how we do care management and hold practices and patients and payers, everybody accountable for the outcomes in a way that is different.
Great, thanks very much. And I'd like to go to Steve next.
Thanks, Mark. Triad Healthcare Network, for those of you that don't know, is the ACO that's affiliated with Cone Health. So I'll kind of give you a little sense of what we've been doing for planning through this. So, as an ACO, we're a little bit smaller than UNC. We've got just over 1,200 physician members. So really our first reaction was to help physician practices who were largely in distress, as Dr. Smith described. So I would describe or break down our, quote, planning for the future in two phases. Phase one I would call COVID crisis, that time in the first 60 days, which it was really chaotic, in which we were really rapidly trying to assist practices to transition to telehealth, keeping in mind that at least in our area, there was so many practices that had never, ever done a telehealth visit. And all of a sudden, they were having to move almost 100% to telehealth. So we were trying to assist them to transition to virtual care, helping them identify potential platforms and providing updated billing guidelines and payer guidelines, which were seemingly changing daily, and also educate them to the various funding that were available for their practices through the CARES Act and provider relief funds, PPP, CMS, all of those things. After the first 60 days of, I would call, COVID crisis, I would say phase two I would describe as kind of riding the wave. We started to recognize, we realized that there could be a lot of good coming from the pandemic in terms of transformation, and we really wanted to take full advantage of the momentum to virtual care and digital care. As a result, we started focusing on really transformation and transition to a new model of care that I like to call health assurance. Not health insurance, but health assurance. It's a term I came across. It's not mine, but I shamelessly stole it from somebody because I really liked it. But it's really much more of a consumer-centric, data-driven, cloud-based healthcare model, really designed to keep people well. I like to think of it almost like a perpetual digital physical, one that would enable us to consistently monitor health and make interventions much further upstream than we've ever been able to do before in order to avoid unnecessary physician, emergency room, and hospital visits. From my perspective, having done this now for the past 9 years as an ACO, the term healthcare has really become synonymous with sick care. And I felt we really needed to come up with something else. This idea of health assurance was really, really attractive because the current healthcare system is really a mass production model that was right for its time, but like almost every other industry business model, we really need to start unscaling and move to a much more mass personalized, nimble, low-cost model. And to me, this is at the core of developing a resilient healthcare system going forward. We need to move from a system of scarcity to one of abundance, and we should be making healthcare as easy to access as Google Maps. And to reach this health assurance model, I think the most important thing we're doing right now is focusing on what I'm calling margin of reimagination. Showing both physicians and hospitals the value of cost avoidance in a value-based payment and risk model. I do not care how much contribution margin a hospital makes on a low acuity admission for a CHF or COPD exacerbation. In the value-based payment world, in my world, we'll generate triple that amount by simply avoiding the admission and related downstream expenses altogether. And the more we can show that, the better. We want providers to move away from this legacy and traditional model of always focusing on top-line revenue, and instead focusing on what actually is being earned and how. Building a resilient health system is going to be really dependent on how we realign provider incentives and earn margins that are aligned with the health and well-being of our communities. We are seeing firsthand, really at unprecedented speed of change, just how much care can be delivered in new ways. And not all of these traditional kind of low-value tests, the procedures need to come back at all. And we need to take this opportunity to redesign care, not just reopen for care. I love what Dr. Smith had said about we don't want to go back. But we have to show providers a path to sustainability by keeping people well. This can only be accomplished really in a value-based payment world. We already know exactly what we got from the fee-for-service world. It'll deliver expensive, inefficient care, fragmented, low quality, and it's a sick care system. We really want to move to this, what we're calling a health assurance system. So really, Mark, for us, in short, we're kind of moving to this health assurance model of the future, but we're also using kind of margin reimagination as a path to get there.
Great, Steve. Thanks very much for those comments. And go next to Rahul.
Well, thank you, Mark. It's great to be here. And just on the topic of resilience, I would be remiss if I didn't say that just because I'm on a panel with Dr. Smith and I've seen we've seen and heard from other physicians in the group, that to me, the most striking thing about these last several months is, and I think it's the core of resilience, is just the incredible professionalism of the U.S. healthcare workforce. It's stunning, and I think of myself, even though I work for an insurance company, as a doctor. But to me, this is one of the most important lessons, one of the things that, one of the greatest learnings from the crisis that we have lived through. And we see it in independent primary care providers that have kept the lights on, that continue to see patients, people that work in hospitals, often at great personal risk to themselves. I think of my own parents, who are 70 years old and continue to see patients. They're both primary care providers in New York. So that to me is the central fact of these last 5 months. As a payer, we are, sometimes I say the financial engineers, at other times I say the bean counters that make healthcare possible. And the thing that we have been the most focused on over these last 10 years has been reducing total cost of care. So the backdrop for this crisis that we are living through is that it comes to us in the midst of modern healthcare's greatest crisis, which is cost. And we have seen, for every year of my lifetime, rate of growth of per capita medical expenditures exceeding wage growth. This is the first time that we've seen that law of physics bend. And it has created this incredible moment in our healthcare system where there's a new openness to maybe thinking differently about how we could pay for healthcare and how we could build a system of finance that is more resilient, and so marries this concept of stability of revenue with controlling long-term rate of cost growth. And that's really what value-based care is. So, we have taken this as an opportunity to push the envelope on value-based care as much as possible. We've focused in particular on trying to stabilize revenues for independent primary care providers. We announced a program called Accelerate to Value. The goal of the program is to true up independent primary care providers to their 2019 revenue levels, and then get them on a pathway to capitation for primary care services. With a few of our hospital system partners, in particular, we have an especially strong relationship with UNC. We have tried to experiment with the concept of a global budget. We can do this at the product level. And many of these are concepts that would have been really difficult or unthinkable 6 or 9 months ago. But I think it's this changing of the laws of physics that has occurred that has created this possibility. So in sum, the opportunity here and the need is stabilizing the delivery system in the short term, but doing it in a way that creates long-term sustainability and long-term advantage for the people of North Carolina and for all Americans.
Thank you, and definitely want to follow up on a lot of the comments that you all have made, very compelling. But maybe we could start with first Karen and Steve on the healthcare provider side. So we've talked about where we are. You all have laid out a path forward about fast forwarding, actually, not snapping back. Maybe Karen, Steve, can you maybe describe one more thing you'd like to see happen to help us move forward now? Is again, it's great to look forward, but we got to stay grounded in all the challenges that we are still facing today and getting through the pandemic. So one area that you'd like to focus on for enabling us to do that better, that hopefully gets us to a resilient healthcare system too. Karen, you want to start? Yeah.
That's a great question, because the ideas and the activities that have already occurred, allowing us to maintain our practices, I look at that as a scaffold, and it is. It's helping us to stay intact, helping us to maintain our businesses. One of the areas of concern that I currently have is having unified and consistent communication with our patients, with the people who we're taking care of, with our employees. The leadership, consistent leadership, consistent communication, it really helps. I'll give you an example. Yesterday, I dealt with 3 people, and one person said to me, "Is this COVID-19 a hoax? Are you buying into this?" And I was like, my goodness, where are we with the communication? In terms of the concrete, one concrete thing that we can do, even as leaders in our own practices, is to be very consistent with the communication. Make sure that we continue to talk about the 3 W's and further enhance the trust that we have with our patients. And along those lines, we need to make sure that we are able to operate in a value-based payment model. I had another patient say to me today, after reviewing her lab and modifying her diabetic medication via telehealth, and she said, "Well, I can't see you again for another month." And I said, "Well, I would love to see you in 2 weeks on telehealth. And let's talk about what happened and did it work?" And she said, "No, that we can't do that." And so somehow we have to get to a point where we are taking care of patients in a comprehensive manner. See, we have to stop the counting and fee for service and be able to take care of people in a comprehensive manner, utilizing population health, utilizing our value-based payment models. And maybe Steve can add to that.
Yeah, Steve, please go ahead.
Dr. Smith, I echo everything you said. The singular unified messaging, I mean, I think this is a national tragedy, I mean, to be honest, and I could not agree more. I think the single biggest impact that has made this possible is really, I have to give credit to Seema Verma and CMS, is how quickly they expanded the services and made payment parity on the telehealth services. That fundamentally, I think that triggered the switch. And if there's any one thing that I think we fear currently, is that if that were to change back, because most people don't realize, we're only 4 or 5 months into this. Prior to this, telehealth wasn't even covered outside of rural areas. And so there was a real reason it had not been adopted. And so obviously it's during the public health emergency, it's certainly been expanded. Our hope, and I think all of our national associations are really pleading that these changes be made permanent and that all the payers will abide by those changes and follow CMS guidelines. That would, to me, I think, to be the biggest thing that would put this whole movement at risk if those things were not made permanent.
Great. Thanks, Steve. We really are obviously living in a new normal now, and I would just second your points about the importance of clear and consistent and repeated communication to help people understand what this means for them. We are talking about masks and distancing and no large groups. We're not talking about that forever, but just for a matter of months, and it does make a difference, as we're starting to see in North Carolina and other states. But you all are talking about a new normal that goes way beyond that. Karen talked about a new normal for how to interact with patients who are used to seeing you maybe once a month or less often episodically. Steve talked about more of a continuous approach to supporting and sustaining health. Rahul, I'm going to go to you with this question. You had some time at CMS, and I don't think I need to tell you the fact of the matter, which is that CMS was able to take these steps. Seema Verma was able to take these steps on telehealth and site of service because we are in a public health emergency. CMS normally does not have the ability to expand coverage so widely. There is legislation being considered by Congress right now to extend at least the telehealth piece of everything that's changed in the pandemic, and that it sounds like you all would like to be part of the new normal. So not just telehealth, but site of service flexibility and more ability to address social factors and things like that along with it. So you can talk about, I know Blue Cross has been doing a lot of thinking about how to sustain some of these steps going forward as part of a new normal after the pandemic.
Yeah, that's a great question. I mean, just on telehealth, I agree with the comment that we have dabbled in this area for many, many years. So Blue Cross has paid for telehealth services in some form for the last 20 years, but it's really been around the edges of the healthcare system. And as any payer, we have been wringing our hands about what will be the effect on total cost of care, on access, on quality. Within 24 hours of the first case in North Carolina, we ripped the Band-Aid off and announced parity payment for telehealth services. That includes payment for phone services, regardless of platform. I believe we were the first payer in the country to do that. And we have since extended that policy. It's an emergency policy all the way through the end of the year. We're committed to doing whatever it takes to support our members and our providers for the duration of the pandemic. The goal is to get to a permanent policy by the end of the year. And to get to a permanent telemedicine policy, we really need to understand what its effect is. So we're looking at who's using telemedicine, what's the effect on patient experience of care, on quality of care. And then, there's this small matter of just getting the fee schedules right. And so it's understand the importance of doing this quickly. But, for example, it's a wonderful opportunity to rebalance payments towards primary care and behavioral health. Once you implement a permanent policy, you will lose that opportunity. And so we want to take the next 5 months until the end of the year to do that. The last thing I'd say on this is that the real goal here, or the ultimate destination, at least for primary care services, we think really should be primary care capitation. And so it's not capitation for the total cost of care, but for the bundle of services or the package of services that we think of as primary care. If you pay a fee to the primary care providers that follows the head, so hence the name capitation, it really unlocks the provider's time. And they are then free to deliver care, right place, right way, right time to their patients, however they see fit. And so that could be in person for someone who's high need with multiple chronic illnesses. But for a relatively healthy person or someone with a straightforward chief complaint, it could be by phone, it could be by email. And so rather than continuing to tinker around with fee schedules for a la carte services, that really is where we want to end up. And in the past, there's been a lot of reluctance in the provider community to accept capitated payments. And my hope is that this has changed the thinking, and there'll be a new openness to this type of payment construct in the future.
Thanks, Rahul. I'm going to come back to our clinicians on this issue, our providers on this issue. But first, Shannon, you talk about all of the public health emergency steps you've taken, and I know it doesn't seem like it's ever going to end the way in the midst of the pandemic now. But can you talk a little bit about how you see these reforms going forward as we head out of the public health emergency and into the Medicaid reforms that Secretary Cohen talked about earlier?
Yeah, so absolutely. There are two things I would say about that. The first is it took us 2 months to turn on all these provisions, and we said never again. This was never again. So we've created a sort of switch process. So in the future, next time we have a pandemic or a huge natural disaster or something like that, it's going to be one switch that we flip, and it's all getting done at once. So we've learned that lesson. The other piece, though, we've already started working on making some of our temporary provisions permanent. And so right now, public comment on the website is our broad telehealth policy, which has dramatic revisions. It's a completely modernized and even more progressive policy than a lot of other Medicaid states have. And so we're really proud of that. It's up for public comment for, I think, another couple weeks. And most of the public comments so far have been 2 thumbs up. We love it. Thank you for doing this. Next month, we're going to be releasing probably 20 or 30 different clinical policies that we're going to make permanent. So when we looked at the whole bundle of things that we turned on for our temporary provisions in the crisis, we then analyzed them to say, which of these actually made us a better Medicaid program, better for the providers, better for the beneficiaries, better overall. And so the PAG has just approved those, a physician advisory group. And so those will go up for public comment in the next week or two. So we're already turning almost half of the emergency provisions we made into permanent enduring policy changes, including parity for telehealth services. To Raul's point, telephonic services are a slightly different beast. In the emergency, we have paid not parity, but 80% of parity. Our belief has been that there is a different value when there is some sort of exam and seeing the patient, that you can see their medicines, you can see their vitals machine, you can see things that are important and have value. But if we were in a capitated primary care world, it would not matter. You know, you do what you need to do to take care of the patient in the best way possible. So I agree that this idea of how do we get to more accountability for the overall health and well-being and less worrying about, is this going to be reimbursed at $10 or $20? We're going to get much further down the road with the changes. What we have seen in our study, I told you that we started studying it on day one when we turned on all these changes. Our preliminary data is showing us that we do not see an increased use of emergency room for people in telehealth. We don't see an increased total number of visits. Our super users, our high ED utilizers, are still high ED utilizers. We didn't fix that problem with telehealth. So we're working on drawing some conclusions. So total cost of care has not been impacted in a way that is concerning at this time, and outcomes don't appear to be, although we're early on, you know, to really study outcomes. But we're studying it, and we want a lot of this to stay on permanently.
Great, thank you. And Karen, I want to get your reactions first to what seem like some of the changes ahead to make more of these public health emergency reforms permanent. So we already heard from Steve that telehealth expansion is something that would be really helpful. But I would take Shannon's comment to say that that's not probably enough by itself. You know, the high ED utilizers are still the high ED utilizers. They're getting more access through telehealth, but obviously you need something broader than that. So what are your thoughts at this point, and maybe how you could talk a little bit of how your colleagues in primary care are thinking about this approach of moving more towards capitation for primary care services, at least?
Let me first comment that I agree that it will take a multi-pronged approach. And when I look at all of the collaborations and partnerships that we utilized to get us through the first 30 days, a good example, we were utilizing the North Carolina Medical Society Foundation Project OBOT platform for our medication-assisted treatment patients. And so we had already engaged, and we were using telehealth on a regular basis for those individuals. And we requested to, let's take this URL and use it for all of our patients. And that's what we did. And so it was that partnership. In Hope County, we also have what's called the Hope and Hope Collaborative, where we have the military, we have the state attorney's office, we have the health department, we had the sheriff's department, we had education. We were already seated around the table. We had the local hospitals, they were already seated around the table. And so when we pulled all of those partnerships and those collaboratives together, it was there. And it was a matter of applying what we learned from the opioid epidemic to now the coronavirus pandemic. And so I don't want to say that the telehealth is going to be, yes, it's major, but it also took all of those other activities. Now, in regard to primary care and sustaining us, it was our partnership with our Alidate ACO and Blue Cross Blue Shield, which quite frankly kept our doors open within the first 30 days. And we recognize that all of the services and activities that were provided between those two entities made a difference. We also recognize that when Dr. Dowler called all the doctors to come together on a phone call, you can rest assured that was the most reassuring moment I have ever had in medicine, that we had a Medicaid, that we had our state entity to get us all on the line and to hear about what it is that Medicaid was going to do to take care of the 30% of the patients in our practice. And so all of this collaborative came together. So we had a mixture of that human interaction, that technology interaction. We had our privates and we had our commercial. We had our players at the table. But in regard to primary care, recognizing what is the actual primary care spend that's necessary to allow us to remain viable so that we're not on shaky ground anymore, that we put value to primary care, and that we continue to get the payment necessary that adds value to primary care. We might just keep some of those patients out of the ED if we can actually accentuate the services that the primary care physicians can do and continue to work with all of our colleagues across the House of Medicine.
Great. Thank you. And just on that point then about capitation, that sounds like a promising direction, but you want to make sure that the payments are sufficient and that you're well supported.
Absolutely. The payments do need to be sufficient because there's so many definitions right now in terms of what is primary care, what services are provided in primary care, and we need to clarify that. And then we need to come up with an amount that really will make a difference to sustain the primary care model. And we're not there in our country right now. Primary care physicians are grossly underpaid. Our students don't even want to go into primary care because they spent a lot of money. And I'm looking at a sign where I know I spent a lot of money, and they feel like that they're not going to get the return on their investment. And so we need to add value in primary care and pay primary care for what we are doing to take care of our patients. We can keep them out of the ED. And if we do that, we will decrease the hospital admissions. And if we do that, we will actually get quality care and make our country, make people, all people, healthy in our country.
Now, Steve, you work with primary care and your accountable care organization, your network that you talked about before, and you also talked about the importance of shifting away from fee-for-service towards more of this population-level payment as a way of helping to sustain all of these reforms. What are your thoughts about what you've heard in terms of how payment fits into where to go from here?
Sure, and again, I think I agree with Dr. Smith's comment. To me, we are in favor of a population-based payment. I think we just want to make sure that the amount is sufficient. I mean, again, giving credit to CMS, one of the things that over the past several years, there have been a lot greater flexibility for primary care to provide services like chronic care management, remote patient management, AWVs, all these different ways to help generate revenue for primary care. Our biggest concern about moving to a population-based payment is a lot of practices have not implemented those types of services. They could be additional revenue to those practices today to help them be more sustainable. And our concern is, again, if you're really building a population-based payment based on historic spend, I think you leave out those opportunities for kind of diversification of primary care services. So my only caution, we are in favor of it, but just like with Dr. Smith, I would say it really we have to define exactly what services are included in that. As she mentioned, not all practices provide the same services. So the devil's in the details, but although philosophically we are supportive.
Yeah, sounds like support for the direction, but some effort, just like we've had to go through to get to this point together to figure out how to do it. I know we don't have too much time left. This has been a great discussion. I did want to come back to something that was mentioned in the first panel that you all have touched on as well, which is to get to this focus on health, and especially to address disparities in health, it's important to look at things that go beyond traditional healthcare. So public health collaboration has been something and the limits of public health have been highlighted in the pandemic. I wonder if you could talk a little bit more about things that we can do through the payments, through these other reforms to get to a better ability to address health disparities and to make that happen in a sustainable way. Karen, you talked about the Hope and Hope Collaborative and how that's building off existing shared data systems. That's part of that data improvement is part of the Medicaid transformation, state healthcare transformation efforts. So maybe I'll start with you and then we'll go to some of the other panelists for some final comments, trying to build in this theme.
One of the best activities that occurred at our one of our local Hope and Hope meetings was when WAMAC Army Medical Center said, we have data, because our problem was we didn't know what the activity was in terms of substance use and opiate use disorder in our county. And the military said, we have data, and a doctor with data can move. And that's what we were very happy about that. I want to say though, it still required us to review those policies that still had a race tone. And how do we get to those policies that are anti-racist? And if that means that we have to dismantle what we're currently doing in order to get to a anti-racist activity and behavior and policies, then that will make a world of difference with disparities. As we are working towards making sure that our new payment models are created, that again, we have to be careful. As these models are created, is it accessible for all people? And I think that is going to be one of the important things for us to do, to take a look at. I appreciate Dr. Dowler saying that the department has gone through and reviewed policies, and that's it. To review, to revise, to dismantle, and make sure that it covers all people in our entire state. The health of all of us will make the difference for the health of those groups who have often and who are still considered as marginalized. All of us deserve good health.
Yeah, and Shannon, Dr. Dowler, you did touch on these issues before in talking about the policies that you're reviewing and in terms of continuing to address this shift towards focusing on health. Maybe some further thoughts on this topic?
Yeah, I think it's clear we have pretty significant health disparities in the state from a long history of issues that we don't need to go into right now. But it is also really clear that if we have any chance of overcoming these disparities, we've got to put a disproportionate share of our resources into correcting them. And so it's not just a one-for-one. We've got to really dig in and invest in overcoming these health disparities. One of the big areas that is where we see a huge lag right now is in the Latinx population, as far as accessing telehealth or electronic health portals or other things, because most of the instructions are in English. Your appointment confirmations are in English. When you go onto a portal to send a message, it's an English platform. Not for everybody, but that's an issue around the state that we've observed. So there's an access issue related to language. Then there's an access issue related to who has broadband. And we have rural areas. Certainly I'm in Western North Carolina. There are a lot of areas here where there is no hope of internet connectivity. But when you look at an income and the ability, even if they have broadband, can they afford to have access to Wi-Fi? Do they have the technology? How do we get those in the hands? And that's some of the unique things we can do in a managed care environment where we can use dollars a little differently to invest in overcoming some of the health disparities by using our dollars really wisely and in a different way. So I think this disproportionate share of energy and resources going into overcoming health disparities is critical and important. And then how do we get access to care, equity as far as access to broadband so people can use telehealth and have access to actual smartphones or computers in their homes, so they don't have to go to Dr. Smith's parking lot and do a telehealth visit on their Wi-Fi using their devices because they simply can't access it any other way. We got to do better for the people of North Carolina than that.
Thanks, Shannon. And Rahul, maybe sort of same question to you. You've heard about, you've stated some of the important directions that you'd like to go in terms of value and keeping these important reforms, but I know Blue Cross has also prioritized steps to reduce health disparities and ensure that these desired reforms really do have the intended effects in that direction. So maybe some further thoughts on that?
Yeah, no, that's a great question. So I agree with comments from Dr. Dowler, Dr. Smith. Within the framework of membership, so we think of the four out of every 10 North Carolinians that we serve who are our members. It's our expectation that our members are treated equally and they are afforded the full rights and privileges of being a member of our health plan. And that's obviously aligned with the goals of everybody else on this panel. There are things that we do which we think are clearly enhancing access to care, like diverting more resources to primary care, investing in primary care services, increasing payments for behavioral health services. So across the board, increasing access. There are other things we do, I think, that require more study or where we have some concern about their impacts. And what I'm really alluding to is that we're changing payment structures. And when we do that, we need to be really careful that we do it in a way that is methodical and careful, and that we're studying the impacts of what we're doing, particularly on equity and on disparities in care, and that we are actually closing the gap and not not exacerbating it. I believe that we are. I don't mean to suggest otherwise. I think the main thing I want you to hear from me is that it's important that we do this in a way that is scientific and careful and methodical. And so what I'm speaking to is the importance of study and really scrutinizing the impact of what we're doing.
Thank you. And Steve, I'd like to close out my questions with you on a similar note. I clearly want to move in this direction of more value, not go back to where we were before. And what are you all thinking about in terms of making sure we do that in a way that reduces disparities and addresses some of these health equity issues?
Sure. Well, one of the things, obviously, having been taking a lot of under value-based payment and risk models now for several years, is just the reality that poverty is a pre-existing condition. And what we're realizing is that the health inequity exists it's not based on coverage, but it's based on a lot of different things, whether it be poverty, systematic and structural racism, discrimination, you name it. But it's not necessarily based on coverage. The biggest thing that we're hopeful for in this kind of transformation that we've seen over the past 4 months is access. Really having more, as we move more to virtual and digital care, greater access to have greater health equity. Now, in doing so, we've also realized that, guess what? Not everyone has broadband. Not everyone has, phones. I think Dr. Smith added this before. And so just recognizing that we can improve access through digital health. However, there's also some barriers that we've got to overcome for a subset of our population that we really have to focus on. But I think those investments will have huge returns for us overall. So access is a big one. The other is, again, I come back to, if we can remove the disparity and really align the disparity in, on the fee-for-service payments and move to a more kind of universal payment, it would make a big difference. I mean, why don't we have good access for Medicaid providers? Because not everyone takes Medicaid. Why is that? Because the Medicaid fee schedule is low. It's this kind of circular this circular problem I'm hoping that we can break as we do look at different payment models here, because I think it's absolutely critical. So if we could, again, move to a different payment model that removes some of the disparity in how we're paying for the care of some of these folks and improve access through digital health, I think those two things will go a long way. It certainly won't, again, solve some of the broader issues, and just remembering that health inequity is a result of broader societal issues. But I think of those two things, if we could do those, it would be a great first step forward.
Well, thanks, Steve. And I want to thank all of our panelists for a terrific discussion, and especially thanks, as Rahul mentioned, healthcare professionals are having to do unprecedented things to help us get through the pandemic. And it's terrific to see all of you coming together to try to make that easier. And as we said, as Karen Smith said, to make sure we don't just snap back to the way things were before. Great discussion about the opportunities and also the challenges along the way to get there. So thank you all very much. And I'd like to thank all of you who joined us today. We've heard about many of the steps that healthcare is taking to do things differently in the pandemic, and how this new normal, while it's a very special new normal for the pandemic, is probably not going to go back to the way things were before, nor do we want it to. We've heard about ways to build on some of the changes around telehealth, around greater access to needed diagnostic testing, around new models of care that can potentially help get to a better healthcare system, one that also takes more steps to address health disparities. We've also heard that this is going to be challenging. It was really hard work to do that initial 60 days, that sort of rapid response when the pandemic began. But people came together from all of these sectors across the state and in different communities in the state to do it. It's challenging to get through the pandemic now, and we're seeing new collaborations to make healthcare work differently, work with public health differently, address the pandemic needs of North Carolinians differently. And looking ahead, it seems like some of those challenges still remain, but it's certainly a strong foundation to build on. And I hope through events like this, we can continue to bring different parties together to identify that path forward. For those of you who are interested in this topic of healthcare resilience and how we improve our response now, how we go forward, and want to learn a bit more beyond what we're seeing from these leading efforts in the state of North Carolina, I encourage you to visit our website at Duke Margolis. We have a section on healthcare resilience, including some national proposals and some studies and reports on things that are happening around the country as our nation and our nation's healthcare system tries to take steps to respond. And in a way that, whereas as Dr. Smith said, we can hopefully fast forward in a way, as Steve Knorr said, toward more of a focus on health assurance and not just a fragmented healthcare system that costs too much and leaves too many access problems and disparities in care. Thank you all very much for joining us today, and we look forward to seeing you again soon. Stay healthy.